Good morning. So, before me, Sir has beautifully covered the heart failure, reserve ejection fraction, HFpEF, what we call commonly. So, I'll be touching today the challenges what we feel and what we get while treating a patient with HFrEF, heart failure with reduced ejection fraction. Most of the time, conventional idea is that heart failure is mostly when the pumping is low, as has been rightly mitigated. That heart failure can be with normal pumping, can be with mid-range, partly compromised pumping, and can be with reduced ejection fraction, as has been told, more than 50%, less than 40%, and 40 to 50%. So majority of patients what we deal in our day in and day out practice, I would not say majority of patients what we deal, majority of patients what we recognize, because a plethora of patients with HFpEF, they largely go unrecognized. So topic today is what do we do in HFrEF therapy? There is a lot of advances being met recently in the last 1 decade in the treatment of HFrEF. If you see in Indian perspective, the mortality of HFrEF patients particularly, it goes significantly high as the time passes. The beauty is in HFpEF patient, they can survive longer, and you need to control the comorbidity associated with the disease, as well as you control the symptoms. That is the main cornerstone of therapy in HFpEF. In HFrEF, the majority of other things also needs to be controlled. When you deal a patient with HFrEF, almost 10% die in the hospitalization in ICU. By the end of 3 years, if you see, you almost lose your 50% of the patients. Initially, we also didn't recognize when we started the practice that we deal with 500 patients with HFrEF. What happens to them? Suddenly, how come the number of patients they keep, new patients are coming and the old patients are not there? When we dig our data and when we compared with the data present in the Indian perspective, we found that by the end of 3 years, you are largely losing your 50% of the HFrEF patients. If you don't optimize the patient and if you don't give them the right therapy at the right time and increase it further. And what is contributing to this mortality largely is lack of GDMT, guideline directed medical therapy. Now the guidelines, they have clearly defined what should be the best therapy in these HFrEF patients, what are the four cornerstone of therapy, when to be started, how to optimize, how to monitor, how to regulate. But majority of patients in India, I'll touch the data later, that they are not on GDMT, and the lack of GDMT, absence of GDMT, and suboptimal dose of GDMT is also contributing to significant mortality in HFrEF patients in India. And optimal GDMT is essential way, like to improve the patient outcome in terms of mortality, in terms of hospitalization, in terms of quality of life. The guideline-directed medical therapy, the optimal dose, this is the best shot in your hand to prevent the mortality and hospitalization and giving them quality of life, and has been endorsed by all guidelines across the world, be it American guidelines, be it European guidelines, and any guideline. Now we'll touch a hypothetical patient, like she's a 58-year-old female. Routinely we see these kind of patients day in and day out. And we are going to ask that question to ourselves because we don't have the question answer time here. She was diagnosed 4 years back with HFrEF. She had NYHA class 2, and currently she is on ACE inhibitor, beta blocker, diuretic, and MRA. And now she comes, like occasionally I do get breathless and I have to stop with my routine activities, means NYHA class 2. So largely asymptomatic patient. These are the medications she is taking: ACE inhibitor, beta blocker, MRA, and diuretic. Her ejection fraction 35%, kidney function normal. BNP is not bad. BNP is also 125. BMI is on the higher side, overweight. Blood pressure is good. Potassium level is good. Now, what would we do in this patient? If I can take a 30-second pause. Would you like to change patient's medication? I'm going back to the medication. Patient largely is stable, all parameters are good, GFR is good, kidney potassium is normal, anti-proBNP is absolutely fine. NYHA class 1, 2, I would say, maybe I would say NYHA class 2. Would you change this medication or not? What would you do? Perfect. So this is the benefit of dealing with such a learned audience. So in a conventional practice, maybe 4 year, 5 year down the line, we would have probably not touched this medicine. Largely in today's practice also, because since we are dealing with learned audience, this is besides the point. Once you get the file in OPD, once you get the patient coming in emergency, these patients, they will be managed like this only for years altogether, because anti-proBNP is fine, my patient is doing good, 4 साल हो गया है, तीनों दवाएं चल रही हैं, कुछ उसमें ऐड करने की जरूरत नहीं. But this is where actually we fail. Majority of studies, they have seen that if you further optimize, you add all four cornerstones of GDMT HFrEF therapy, you further keep reducing the mortality, you further keep reducing the hospitalization, and further keep improving patients' outcome and quality of life. So in this patient, certainly we are going to do what has been told. We will substitute ACE inhibitor with ARNI, and we will certainly will add SGLT2 inhibitor, because that is the cornerstone, one of the four pillars of therapy. It has to be there. There's no non-negotiable unless it is contraindicated. Why are we substituting ACE inhibitor? That also we will touch, because data has shown that even in asymptomatic patient, if the patient is MHA class 2 and beyond, the ARNI does better and gives a better clinical endpoints compared to ACE inhibitor or ARB alone. So that was the data which was there in paradigm HF that we will just touch. So if you start a patient who is not taking GDMT versus if a patient who is taking GDMT, you are decreasing his mortality by a risk of by almost a whopping 29%. The relative risk reduction is there. 29% relative risk reduction is no game. It's not a joke. It's a substantial reduction, which no patient should be deprived. The purpose of this taking this talk was making your audience and you now going back to your practice and you now going back to your talks, because all of us must be engaged in say various academic lectures and academic this thing. We all need to make aware our medical fraternity down the line that if you are not giving any of these four molecules when it is indicated, we are actually not doing justice to the patient. So what guidelines recommend for HFrEF therapy? ACC guidelines, as I mentioned, hospitalization for HFrEF is a critical opportunity. And we all have seen in our practice, once the patient is hospitalized with heart failure, that is the best part to initiate, optimize, continue his GDMT. If the patient is not there, please start. If not contraindicated, if the patient is already there, please optimize. And if the patient is there, optimize. He will not have been in the ICU in the first place, but if he was because of some other reason, please continue with GDMT. Do not discourage and do not remove that. So continuation of GDMT during hospitalization of for heart failure, this has been shown to decrease substantially the risk of death and the risk of further hospitalization. And that we know that patients who with heart failure, once they are discharged, in the first month, almost 20% patients, they come back to hospitalization. In the first year, almost 33% patients, they come with hospitalization, repeat hospitalization. And the patients who are coming with hospitalization, the mortality in those patients are almost 25%. So the data is staggering. We all know that. Where there is some inertia, sometimes clinical inertia, sometimes you don't want to step up, sometimes you don't want to land up in your own created complication, which is just a myth. We will just try to break. So the ACC guideline recommends the sacubitril valsartan ARNI as the first line of therapy. No doubt about that. In any patient with HFrEF and MHA class 2 or beyond should be given ARNI. If the patient is on ACE inhibitor ARB, well tolerated dose also, that should be substituted with ARB with ARNI. And not only that, like when the paradigm HF came, the study was the patients were given ARB and then they were substituted from ARB to ARNI. Now, enough data is there that shows even if your patient was not an ACE inhibitor, not an ARB, first time diagnosed, you please directly start with your ARNI. Don't wait that I will start with ACE inhibitor first. If he is tolerating, then I start ARNI, which was initially a practice when the molecule came 8 years back. But now we have enough data, enough experience that we don't need to do those titrations. You can directly start patient on ARNI. So the ESC guideline also, as I mentioned, American guidelines and ESC guideline, all guidelines, they have recognized the importance of ARNI in our management of HFrEF patient. Now, what is the evidence backing? As mentioned, Paradigm HF, the major landmark trial, around 13,000 patients, largest clinical trial in HFrEF. And the best part is that it was this molecule was not compared against some placebo. This was compared against an established molecule, losartan. So if the patient is already on an established molecule, if it is going to further decrease the mortality or morbidity or not. So these patients were on enalapril, then certain patients were discontinued and put on ARNI. Now compared to an established molecule, there was almost 20% relative risk reduction in terms of mortality and heart failure hospitalization. So established molecule was already there, like our hypothetical patient, she was already an ACE inhibitor. If you change that patient and put this patient on ARNI, you are decreasing her mortality and heart failure hospitalization by a whopping 20%. There should not be any denial in that. And how do we up titration of in the OPD data? That shows it takes almost 7 months, a good 6 to 7 months to reach to the optimal dose of heart failure optimization medicine. And it is not only for our ARNI, it is also for the beta blocker and MRA. The important thing is that in this data, this is also important point to understand that even if you're giving beta blocker and MRA, your Optimization and up titration of RNA has not been changed. So while titrating, up-regulating the other four pillars of the medical therapy of GDMT, you can still continue with up titration and regulation of your RNA. So this is the important data which we all need to see. Despite all the evidence, what is the use of RNA in India? This was the slide which caught my attention. Despite we trying to use in almost every patient, the actual penetration of RNA in India in HFrEF patient pan India in heart failure registry is only 4%. Now this is why I told you, since all of us are involved in educating people, physicians, GPs down the line, we all have to ensure that once your prescription goes back to the previous treating physician and doctor, he's realizing, no, I have missed it. Doctor has started, now I should continue. And this is a message which probably we need to continue. So, and RNA, when it came, there were a lot of apprehensions were there. Probably over a period of time, we have sorted those apprehensions. But still, when somebody starts this molecule new, or somebody who started in the recent couple of years, they always fear regarding certain things. नया molecule है, kidney खराब हो जाता है, potassium बढ़ जाता है, BP कम हो जाता है, and initially when the molecule is there, we try to find all excuses not to start the molecule. We all have to ask ourselves, and I'm also part of it. When the molecule comes, and once you are convinced regarding the science behind the molecule, only then you can convince your patient. As long as doctor is not convinced, you can never convince your patient. If you are convinced, yes, this molecule is important, this is going to save a life, and this is going to save a hospitalization, and in turn, it is going to save a lot of money, and these things, you will convince your patient. Now, if you see the barriers, and in this barrier, what is the yellow line is when we are not giving ACE inhibitor, ARB, and beta blocker and ARNI, almost 2/3 of patient, there is no contraindication. In 2/3 of patient, there is no contraindication where there is no reason why we are not giving. And other, like we commonly know in some medicine is hypotension, then hyperkalemia, and all these things. But in 2/3 patients, there is no reason. So that can only be covered by education, more and more awareness among our medical fraternity. I will touch the other three major limitations in optimizing GDMT. One thing is hypotension, we are all worried of. Second thing is hyperkalemia, and third is renal impairment. So in RNI, whenever we are starting, we are looking for all these things. We are trying to mitigate all these complications and side effects. First, we'll touch hypotension. Hypotension in HFrEF patient is a ominous thing. But what is the real hypotension? Is the hypotension really a number of 90/50 or 90/60 or 100/60? Or is it something else? Many times what happens, you started RNA at the blood pressure of 120 and the patient's BP comes to 102. You start decreasing the dose or you start removing the dose. So hypotension in a patient who is been optimally optimized is a bad sign, because that is one time it is showing it is a low cardiac output. The cardiac index and cardiac output has gone down, which is associated with poor outcome. And second side, if the patient is undertreated, he has not been given the cardiac modulating and homeostatic modulating agents, so it will further cause the low cardiac output, and that will increase the mortality. So how to break this cardiac cycle? How to break this vicious cycle? So patients, those we already know that what is responsible for majority of remodeling and the worsening cycle in patients with heart failure, particularly HFrEF patient, is neurohormonal, the RAS activation. RAS activation as a sympathetic activation. If you continue that, that will cause vasoconstriction. How do we break that? By RAS inhibition, by beta blocker, by MRA, vasodilator. If you see all these molecules, they do what? They basically act on the RAS system. They break that. And with neprilysin inhibitor, we allow the peptides, the nitric peptides, to act longer. And this will in turn cause vasodilatation. And vasodilatation will decrease the cardiac load, will increase cardiac output, decrease cardiac stress. And ultimately, this will cause the lesser stress over the heart and will prevent cardiac remodeling. Will set in a tone of cardiac reverse remodeling. So this will in turn decrease blood pressure. But that decreased blood pressure is not hypotension, unless the patient has symptoms or signs of hypotension. Sorry. So the main limiting factor, as I mentioned, the blood pressure number is not a hypotension. If your patient is having worsening renal function. Now, worsening renal function can be because of many reasons. It can be really hypotension. It can be because of cardiorenal syndrome. It can be because of overdose of diuresis. So you have to identify which is the thing which is causing this hypotension. If my patient is having postural symptoms, postural giddiness, that is hypotension. Number alone is not hypotension. Most of the patients, when I am dealing a patient with ejection fraction 15-20%, I keep their blood pressure deliberately at 100. I ask them, your blood pressure margin is 100 plus minus 10. Anything above 90, less than 110, I'm happy. If it is more than 110, I'm worried because, not worried, maybe I'm happy. I get a chance to optimize further the dose of arni. But 90, 96, 85 patient roaming around, eating well, sleeping well, having adequate diet, that is not hypertension. Anything more than 120 in a patient with ejection fraction of 25 is a problem that we need to bring, because you have to understand a ejection fraction of 60%, if 140 is a hypertension and increases the cardiac load, ejection fraction of 20%, how come 140 is hypertension? For that patient is 110, 120 is hypertension when you need to bring it down. So any change in therapy of symptoms of hypertension need to be present. If you are going to decrease the dose, there has to be symptom of hypertension in terms of giddiness or postural symptoms and all. And in case of symptomatic hypertension, now many times if hypertension is there, what will do? Since I have started ARNI, I'll decrease ARNI first. That should not be our target. There's most of the time, if there's no obvious sign of congestion, it is the diuretic which is responsible, because patient is being diurized when he had 4 liters of extra fluid versus when he has no extra fluid, the dose of diuretic is same. So the first drug you need to act on is diuretic, because it has no mortality and morbidity advantage. So first drug to act is there, is decrease your diuretic. Second drug, if you're giving nitrate and vasodilator like hydralazine and all these things, they are second line medication. They're not first line medication. So then we'll decrease on, if the patient is not having volume congestive symptom, we'll decrease the nitrate first and hydralazine first, rather than touching a RAS inhibitor, ARNI. After all these things, if still hypotension persists and there is no other explanation, only then we'll consider decreasing the dose of RAS inhibitor. That is last in the list, because the benefit is maximal. So impact of on low blood pressure, even if with low blood pressure, those who are having blood pressure less than 110, there is a still 12% mortality reduction is there. If you see the graph, BP between 110 to 120 versus BP less than 110, the mortality reduction is same. So death after hypotension, there is no increase. If the number hypotension, if you see, it doesn't increase the risk of hypotension. Now coming to hyperkalemia, which is again a major issue, which you find we'll start the ARNI and the potassium will jump. It is not so common. However, you have to be vigilant regarding potassium, because these HEF-REF patients, they are already at the risk of arrhythmias. You can't add one more factor in terms of hyperkalemia to cause further arrhythmias. So whenever we're starting ARNI, we always make sure that we are monitoring his renal parameters, potassium parameters, and all these things without being afraid, and finding it out what is the factor responsible, what is the molecule which I'm going to touch first if my patient gets hyperkalemias. So with growing number of CKD and heart failure patients taking RAS inhibitor and MRA, hyperkalemia has become more common. We are giving diuretic, pre-renal AKI, hyperkalemia. We are giving MRA, hyperkalemia. We are giving ARNI, hyperkalemia. And then the cardiometabolic syndrome, cardiorenal syndrome, that also will cause hyperkalemia. Identifying the right source and correcting the first is important. So hyperkalemia increases decline function, no brain in that. If the GFR is more than 60, hyperkalemia is less, still there. But if GFR is less than 60 with worsening renal function, the chances of hyperkalemia goes high. Why it is important? Because if your patient's renal function is compromising, without any medicine also, because of the prolonged low cardiac output state, your patient's renal function is going to get compromised because of age, because of diabetes, because of low cardiac output. There's so many factors. You be more vigilant if the patient's renal function is going down from 1.1 to 1.4, GFR going from 65 to 35. You be more vigilant regarding potassium. Like now my patient probably can have more and more episodes of hyperkalemia, but that doesn't mean I'm going to stop my therapy unnecessarily just because of out of risk. So reduction of RAS inhibition may lead to poor outcome. 9% patients admitted with HEF-REF, they have hyperkalemia in our emergency. What the patients they come? 10 to 38% patients hospitalized who receive ACE inhibitor, they develop hyperkalemia, and 10% patients prescribed ACE inhibitor, they develop hyperkalemia. So we know when we start these molecules, if the volume status is not correct, we have not kept the patient equivolumic, euvolumic, not like hyper, not like hypo. The chances of hyperkalemia would be on the higher side. If the patient takes some NSAID, gets dehydrated, has diarrhea, vomiting, has infection, there are high chances the patient will have hyperkalemia. So what is the impact of ARNI over this thing? If you see in the same paradigm HFS study, this was seen compared to enalapril, ACE inhibitor, which was earlier the class 1 indication. Now enalapril, this also causes hyperkalemia, but in a lesser incidence. The incidence of hyperkalemia with ARNI, with Vimada is lesser compared to this ACE inhibitor. And hyperkalemia incidence, if you see like from 5.5, more than 5.5 to 6 is almost equal between is equal between hyperkalemia and ARNI and ACE inhibitor. But severe hyperkalemia, where the potassium goes more than 6, is significantly lesser with ARNI. So what we are mostly concerned, potassium बढ़ जाएगा, patient मर जाएगा. This is lesser with ARNI compared to your previous old hyperkalemia. Renal impairment, I will try to touch it fast. Can we go ahead for 1 minute, 1 minute? So over last 30 years, RAS inhibitor has been shown to improve quality of life. And the cause of worsening renal function, as I mentioned, is multifactorial in these patients. Chronic low cardiac output, the other metabolic factors like diabetes and blood pressure, medication, age, everything is going to compromise the renal function further. And lower incidence of elevated serum creatinine with ARNI compared to ACE inhibitor in patients with chronic heart failure. So again, if you are going to give a RAS inhibitor, the ARNI is safer than ACE inhibitor in these patients with elevated renal function. And there's lower rate of discontinuation with sacubitril valsartan compared to enalapril in patients with HFrEF. If you see here also, like the rate of worsening of renal function, if you take a patient on historical control, like those who were ACE inhibitor ARB, over the passage of time, the renal function deteriorates. The GFR is falling from 63 to 55. However, if you put the patient on ARNI, gradually the renal function improves because it takes care of the hemodynamic parameter and sets a tone of cardiac reverse remodeling into the picture. And ARNI reduces the risk of worsening renal function versus ACE inhibitor. There is 11% reduction in the risk of worsening renal function with ARNI compared to the conventional ACE inhibitor ARB. So again, this myth that this will cause further progression of the renal function, deterioration of renal function is not right. This actually causes the slower progression, and sometimes with improvement in LV function, it actually sets the tone reverse and makes the LV function improve. So in patients with mild or moderate renal dysfunction, you don't need to compromise with the dose of ARNI. If the renal function is impairment is severe, like less than 30%, then you gradually start with lower dose and gradually optimize and up titrate. Important thing is that whenever you're starting in a patient with borderline blood pressure, like 100, 110, start with 50 milligram. In many times, we start with 50 milligram half BID also. That's not a dose, but Indian patients, they don't tolerate. In good number of Indian patients, they don't go to the level of 200 milligram BID. I hardly have in my practice, if I have 1,000 patients with heart failure, not more than 5% patients they tolerate 200 milligram BID. That's a fact which I've seen. Majority of patients they reach to almost 50, one and a half kind of 100 in the morning, 50 in the evening, or 100 morning evening. Majority patients they stay in the same range. But important thing is that you will not stop up titrating till you have reached to the barrier, either in terms of tolerance or in terms of blood pressure. So different brands, I think, will not touch that. We all know that reverse research molecules are always better than generics. And conclusion. So lack of GDMT, as I mentioned, is still the penetration is less than 4%, which we all need to look into. And when we all know that when we add all the 4 pillars of medical therapy, GDMT in a patient HFrEF, we are substantially going to decrease his mortality and morbidity, heart failure hospitalization. ARNI is first line therapy in naive patient, ACE naive patient also, when nothing was started like ACE inhibitor ARB, and when it was started, patient stable, even then, switch your patient to ARNI. And sacubitril valsartan has all safety profile as we have just discussed in terms of hypotension, hyperkalemia, and worsening renal function. Thank you so much.